Good morning everyone. I am Dr. Alka Gahlot, Professor Reproductive Medicine. Today I am going to take a class on azoospermia. The incidence of infertility is approximately 10 to 15% and half of the cases are because of the male infertility and 20% of them are azoospermic. So now we should know what is the azoospermia. Azoospermia is a condition in which sperms are not detectable in an ejaculate even after centrifugation at 3000 G for 15 minutes. Azoospermia can be classified according to the cause, like obstructive azoospermia when obstruction is there in the genital tract, or non-obstructive azoospermia when there is no obstruction but there is hypospermatogenesis. Or at the cause, like if there is testicular cause, there is pre-testicular cause or post-testicular, the azoospermia can be classified. We know that there is secretion of the GnRH hormone from the hypothalamus, which acts on the anterior pituitary and helps in the release of FSH and LH. FSH acts on the Sertoli cells and helps in the spermatogenesis, while the LH acts on the leading cells and helps in secretion of the testosterone. This testosterone is necessary for the development of the spermatozoa for the spermatogenesis. So when testes are at fault, then we can say that this azoospermia is because of the testicular causes, and when there is problem pathology with the hypothalamus or the pituitary, then this is because of the pre-testicular causes. And if there is obstruction, the testes are normal, the hypothalamus and anterior pituitary are normal, but there is obstruction in the genital tract, then we can say that this is because of post testicular cause. Now cases of post testicular azoospermia or obstructive azoospermia is 17 to 51% where the sperms are found but they are not present in the semen because of the obstruction. And the obstruction can be there at the level of the epididymis, vas deferens, ampulla of vas, or at the level of the ejaculatory duct, and it can be congenital or the acquired. Congenital, when there is congenital absence of vas deferens, which can be bilateral or the unilateral, or because of the vasectomy or some kind of infection of the genitourinary tract. Non-obstructive azoospermia can be because of the testicular failure. Either the sperms produced are very less or there is no sperm production. So it can be because of the primary testicular failure or secondary testicular failure. In case of the primary testicular failure, when we do the hormonal analysis, we find that there is hypergonadotropic hypogonadism, and it occurs in 49 to 93% of the cases. There is defect in the production of sperm in the testes itself. In cases of the secondary testicular failure, there is pathology with the pituitary or the hypothalamus, and this is when hormonal assay is done, there will be hypogonadotropic hypogonadism, and it occurs in 70 to 51% of the cases. Now, how to evaluate a male with azoospermia? We have to take the proper history, do the proper examination, the general examination as well as the local examination and the investigation. In history, we have to take the sexual history if there is any erectile dysfunction, or there is any delayed onset of puberty, any history of anosmia or sexually transmitted disease, any infection history, genitourinary tract infection, or any kind of surgery on the bladder, neck, retroperitoneal, lymph node surgery, or the bladder neck surgery, or spinal cord injury. So all these history is very important, which we have to take. On the examination, we have to look for the virilization of the male partner, the height, and if there is any gynecomastia, presence or absence of the gynecomastia, and abdominal examination has to be done, especially at the inguinal region, to see if there is any scar mark for the inguinal surgery or the hernia repair or for the undescended testes repair. Now, while doing the scrotal examination, we have to see the size and the consistency of the testes. If they are firm in consistency, that is normal, and size is approximately 15 to 25 ml, which can be compared with the Pradar oxidometer. And also have to palpate the vas difference. Vas difference, if it is present, that rules out the congenital absence of vas difference, and the presence and grading of the varicocele also has to be done. While doing the investigation, first investigation is semen analysis. If it is normal, no further investigation are needed, but if it is abnormal, if there is azoospermia, then after 2 to 4 weeks we have to repeat the semen analysis. On single basis we cannot decide that if the patient is azoospermic. Further endocrinal evaluation like the FSH, serum testosterone, LH, estrogen, prolactin and TSH has to be done. In azoospermic patients, genetic karyotyping is very important, like the genetic karyotyping for the numeric abnormality like in the Klinefelter syndrome, and Y chromosome microdeletion has to be tested. For the congenital absence of vas difference, we have to do CFTR gene mutation testing. Now in the semen analysis, what is important is the volume of semen. In case of the obstructive, it will be on the lower side, while in non-obstructive it will be normal. In case of the obstructive azoospermia, the pH will be on the acidic side, because obstruction is normally at the level of the ejaculatory duct level, and there is only prostatic secretions which are present in the semen, which makes it acidic. So when there is obstruction, we are going to get lower volume and acidic pH. Now with help of the hormonal assay, we can differentiate between the hypogonadotropic hypogonadism, in which LH, FSH and testosterone will be on the lower side. In cases of the obstructive azoospermia, all these findings will be normal, and in case of the impaired, severely impaired spermatogenesis, FSH and LH will be on the higher side, while testosterone will be low. So genetic evaluation by Q microdeletion has to be tested, which if the findings are that A, Z, F, A or B are present, in that case testicular biopsy should not be advised, but in case of the A, Z, F, C kind of microdeletion, we can go for micro TC, and in 50 to 70% of cases we are going to find out the sperms. So how to manage? In pre-testicular azoospermia, gonadotropin releasing hormone therapy can be given, or HCG followed by HMG. HCG initially has to be given if there is decreased testosterone, and it should be given twice weekly, followed by HMG, or if these treatments are not effective, then we can advise for donor insemination. In cases of the testicular azoospermia with micro TC, we can see if there are sperms, and if we are not able to find any sperms, then donor insemination is the treatment. In post-testicular azoospermia, as there is normal spermatogenesis, only obstruction is there. In that case, we can advise, if history of vasectomy is there, we can advise for end-to-end anastomosis, or if the patient is not ready, we can go for PISA and TISA. Surgical correction depends upon the expertise of the surgeon, and we have to counsel the patient accordingly. So these are the different methods of sperm retrieval technique, surgical methods, which can be done in cases of the obstructive and non-obstructive azoospermia, like PISA, MISA, TISA, TC and micro TC. This is all about azoospermia. Thank you.